Yes.
Thank you. Welcome everybody to our joint conference committee for Zuckerberg San Francisco General on this date, April 28th, and I'll ask our secretary to call the roll.
Sure. I'll start with you, Commissioner Chow,
Present.
President Green,
Present.
and Commissioner Christian.
Present.
I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caregivers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Thank you. The minutes are before us, I guess, for approval. If we have a motion, please.
Move to approve. Second.
And I have actually two corrections. Commissioner Chow let me know he would like on page 2 a rephrasing of a question that he asked. Page 2, second paragraph, his statement as it was crossed out, and he would prefer it say, Commissioner Chow asked if there's advance warning for an upcoming survey. And then also he noted on page 9 that the second paragraph, I had president and then skipped putting in green and then moved on to the verb. So as you approve and vote, please note that those corrections will be made in the final version.
Is there a public comment?
No public comment.
So we're ready for a approval vote. All those in favor, please say yes.
Aye.
Yeah.
All right. Thank you.
There being no opposition, we'll move on to our next item, please.
Item 3 is a regulatory affairs report.
Good afternoon, Commissioners. Emma Moore, Director of Regulatory Affairs, here to give the April 2025 Regulatory Affairs Report. So first up, under pending surveys, one update since this report was generated is that our Joint Commission Stroke Survey has been scheduled. It's tomorrow and Wednesday. So we're excited that that will be getting taken care of. So that'll be bright and early tomorrow. Other things that are pending are we are anticipating CDPH visiting the campus on Thursday as the two unions, UCSF unions, AFSCME and UPTE that I spoke about last month, will be having another one-day strike. So we are anticipating that CDPH will be on site to learn more about that and ensure that safe care is being provided. Otherwise, I have no major updates on those 3 pending surveys, outpatient dialysis, 4A licensing, and the general acute care hospital licensing survey. So we continue to await those. In terms of survey activity under Section 2, we had one survey visit in the month of March, which was 2 hospital-acquired pressure injuries that we had self-reported that CDPH came out to investigate, and there were no deficiencies associated with that visit. Third section, plans of correction submitted. There were none during this time period. So moving to the second page, or Section 4 of the report, the facility reported events for the month of March. So year to date, we are at 22. Largely due to privacy breaches as well as sexual assault allegations, almost all of which have been unsubstantiated. For the month of March, we had 3 privacy breaches, 1 sexual assault allegation, and then 1 other, which was the previous strike notification. And to go into a bit more detail, because I know there's been interest, the privacy breaches, there were 2 of them that were misidentified patients. So one was a courier picked up the wrong medicine and delivered it to the wrong house. They did address that, were able to get it picked up, and everyone got the correct medication. So there was no error there, but there was a miss on which patient. And the second one was some immunization records for someone were stuck in the wrong folder and given to the wrong patient. So those 2, I think I would term them as non-malicious, but not correct identification. The third one was still under investigation, but evidence of snooping. So intentional, someone intentionally going into a record of someone that they knew from outside of the hospital. And lastly, the sexual assault allegation had to do with a patient alleging a thigh touch, which would not meet our definition, but he very clearly alleged it was a sexual assault. So out of an abundance of caution, we report all of those such events or allegations to the state, but I do not anticipate any deficiencies associated with that. And I think just to also, since we're talking about privacy breaches, I got an update from the privacy officer, and she did a look into 2025, and I had shared last month that we had a higher volume of privacy breach reports coming from the SAFE system or the unusual occurrence system. And year to date, 66% of the breaches that have been determined to be reportable have come from the SAFE system, which in 2024, only 27%. So a significant increase. The other trend that she identified was at least 3 of the cases were self-reported, which I think is a new trend that we have not previously seen. And so I think that is suggestive of, again, not to say that there's actually been an increase in the number of privacy breaches, but that from a surveillance standpoint, the identification of them is happening because people are self-disclosing, and I think being more aware and transparent about that. Moving to the next section of the report, section 5, the plan of correction monitoring data. So the PIPS minutes have greater detail, but we are almost done with the Joint Commission and Nursing Care Center triennial survey monitoring. There's just a couple of elements that are needing a bit of tweaking, and same goes for the inpatient psychiatry complaint validation survey monitoring. Almost all of that got closed out at last week's ALCC committee, and same goes for the 4A findings as well. So we're trying to clear the docket of monitoring items before we, potentially get some more tomorrow. Moving down to the 4th page of the report, the complaint data, no meaningful updates to report on pages 4, 5, or 6 of the report. There hasn't been any major shifts. CDPH has not been significantly active in the last month. And on page 7, thank you for the feedback regarding the color coding. We will get that fixed for next month. Excellent catch. With that, I will stop for questions.
Thank you. On page 7, just to explain to our fellow commissioners, I wrote that since we were using green for clothes without deficiencies, it would be nice to use them in all of our charts. So,
Thank you.
thank you. You're saying we have no public comment?
No public comment. The folks who are in the room are staff and guests of staff, and then there's no one who's been given permission for remote public comment.
Okay, so then we can proceed with commissioner comments. No comments.
Wonderful report, as always.
The reports are, I think, even more helpful with the breakout of the facilities reporting and where we're standing. So really do appreciate it. I do wonder on the, as I was reading what you're using as progress on page 3 for these items, do we, and maybe it would be helpful to understand the dates that those surveys were done so we know what progress you're moving towards.
Sure. And if it's all right, we may include that as part of the PIPS minutes so that it goes in closed session just from a detail standpoint, but we will work to include that next month.
Yeah, I'm not talking about the 80 of the 82, but just the date the surveys were done so we know what the time cycle is moving forward. Okay.
Yeah, happy to.
Okay. Thank you.
All right, thank you very much.
Next item.
Yes, we can move on to the hiring and vacancy report.
Good afternoon, Commissioners. My name is Kim Walden, Director of Operations for HR, and I'm standing in for Kim Knox-Mitchell, who couldn't make it today. I'm here to share the HR highlights for the month of March. Overall, we saw a very small increase in the vacancy rate from 1.54% in February to 1.55% in March. There were 5 separations total with no retirements. We hired a total of 34 employees, including 22 RNs in various critical areas, including critical care, emergency care, and med-surg. In May, we'll have an ICU experience training class with a cohort of 6 RNs. As an update to the hiring freeze since January 9th, The mayor's office has approved 267 positions in February, and recently this month, they approved another 277 positions, totaling 544. These were based on executive leadership's priorities. There continues to be 7 classes that remain exempt from the freeze that are patient-facing and in critical roles, including RNs and nurse practitioners. And filling these vacancies, approved vacancies, remains the top priority for HR while working on decreasing the time to hire. And also keeping up with the Mayor Lurie's initiative to break the cycle, we hosted a hiring event March 28th and 29th, focusing on behavioral health clinicians, entry level and senior level. And 37 candidates registered. We selected 30. On April 9th and 10th, we had onboarding events to process these candidates pre-employment. And they're all starting within this month and early next month, May. And to close, I'd like to share that HR continues to look at ways to streamline our processes, the hiring process, and create efficiencies. Beginning next month, the hiring and selection team will be centralized. And I'd like to introduce you to the Director of Hiring Selection, Erica Thorson here, and the Manager of Hiring Selection, Jennifer Magnuson. And going forward, on behalf of HR, they will be providing the report out to you all. And I'll stop for any questions. Thank you for your time.
Okay. Commissioners, questions? Commissioner Green?
Yes, so it's really encouraging to hear that this freeze that we thought was really frozen actually has flexibility. Are there any areas that you feel, you'd still like to have? I mean, obviously there's always a need for more hires, but is there any area you feel is critical that the freeze is still affecting? And then on the mental health side, you said 30 people had, I guess, been engaged, but are they all actually going to take jobs at the general?
These are actually behavioral clinicians across DPH.
Ah,
I don't have the exact number for the general, but I can provide that in a follow-up. This round of approvals for the mayor's office was a little different. We received them in 2 phases. The first phase had 100 plus, and then a couple weeks later, we had another couple hundred. They prioritize the clinical roles, and so we're still working with them on the management roles. And so, yeah, we're currently focusing on providing justification for those positions.
thank you.
Commissioner Kristen?
Thank you. Thank you for the report. I may not be phrasing this correctly, but hopefully you'll understand what I'm asking. So can you give a little bit more context for the difference between behavioral health clinician and behavioral health worker type positions, and which the numbers that the mayor has opened up more slots for one versus the other? Just a little explanation for the uninitiated about the difference between those 2 categories.
Yeah, so the behavioral health clinicians are the 2930 working directly with the clients to provide services. And then the other health workers are the other classifications that we're focusing on, health workers 2, 3, and 4. I can provide additional information, take your question, and kind of get a better explanation of the various roles that make up these 2 classifications. But definitely in this first and second round, there were many in these 2 roles that were approved.
Thank you. That would be helpful to have a little breakout for people who aren't familiar with the differences between the categories. And so in the clinician category, do most of those people have the ability to diagnose or not necessarily?
I'd like to, yeah.
Good afternoon, Erica Thorson, Director of Hiring and Staffing. And yes, the behavioral health clinicians actually are licensed, so they are able to diagnose. Health workers are not. That is a more I will say patient facing, but not diagnostic in terms.
That's very helpful. And to the extent that you can, even more broadly, but a little more specifically, a behavioral health worker, patient facing. So interacting with the patient, the client, helping them with areas of need that are not clinical per se.
Health workers is a very, very broad job title, and a lot of different duties fall into that. So I would hate to give you something
Sure.
specific and be completely off, because it does vary from health worker to health worker based on clinic, location, the clientele that they're dealing with. So I don't have a necessarily straight answer for that one, unfortunately.
Sounds like they're very versatile and flexible.
Very much so, yes.
And they can be uh, sent to different areas and for different needs that may come and go.
Yes,
Thank you.
thank you.
I was wondering, looking through the vacancy lists and so forth, that psych techs still represent a challenge, and perhaps you could explain to us what the challenge is in, is it because there's a shortage of them, or we don't pay enough, or what do you think is the reason that we have this difficulty?
Do you want me to jump on this one? Sure, sure. So our licensed psych techs, we've actually been working on a project, I should say, with City College of recreating their licensed psych tech program at City College. We're creating curriculum. We're actually looking at launching that. It's not a quick process. I would say within the next 18 months, give or take. The closest licensed tech school, most of them are in Napa. So geographically, it's not convenient for folks that are LPTs to work in San Francisco. Many of our LPT employees are commuting from Napa into the city. So that's part of the problem, right? Is that there's a commute issue, which in turn turns into a retention issue. We are looking at ways to resolve that with retention ideas of how can we make sure that those folks that are, say, commuting from the Napa area do stay with us? How are we working through that? We're working very closely with the union actually to help with some retention measures. But we're really hoping that the LPT program at City College is going to help us build a pipeline moving forward. Again, we're looking 18 months down the road or so, but we're looking at getting that launched so we will have that pipeline moving forward, and we won't have the conundrum that we're in today where there simply aren't enough candidates to fill the positions.
All right, thank you. Ms. Mitchell, you mentioned that there was going to be a change in reporting, which also then represented a change of, I guess, the status of the office, which is going to be placed back in the central office. Could we understand what that is going to do, and how does that affect the fact that we've been so successful at General with a dedicated team?
Sure. So we will still have dedicated teams. It won't be dedicated by location. It will be dedicated by job classes. So we've actually decided to break out the teams where we will have a team that's overseeing clinical. So everything that would fall under the SEIU MOU, the RN MOU. Then we would have another team that is handling the behavioral health clinicians, the core restore beam projects would fall under another team. Then lastly, we would have more of what I'll call our administration team, which is going to be handling our operations, things along those lines. We feel as though by narrowing down the focus of your hiring analysts to specific job classes, we can keep things moving much more. They can flow a little bit better rather than having somebody at Laguna handling Laguna vacancies for RNs as an example, and then somebody different handling that for Zuckerberg. So we wanted to consolidate that and see how that's working out. So that transition actually happens next week. We're working through that transition with the hiring analysts as we speak.
So how that is going to change our emphasis and our reporting?
It will not, other than it will be myself and Jennifer coming in to present the reports. The reporting will still be the same. We will be pulling the information from the same databases. The teams will look very, very similar, but there will be no change. The effort will still be ensuring that we are staffing ZSFG to the highest of the abilities.
Okay, any further questions? Thank you very much. We'll look forward to your report next month.
Thank you.
Thank you.
On to the next item, the CEO report.
Good afternoon, Commissioners. Mr. Morowitz, Susan Ehrlich, CEO of the department. I'm here to talk about the report you have in front of you. And as you can see, there are many things to celebrate in our report this month. I wanted to focus on a few things, and of course, happy to answer questions. And I'll start with the narrative as usual. So first of all, on number 3, I wanted to make sure you knew that that photograph that's about bringing awareness to colorectal cancer is a giant half colon blown up. And the team was very excited about bringing this half colon onto the campus and also to bring awareness to screening for colorectal cancer. So the event was a big success. It was a lot of fun, and it was definitely an Instagram moment. I also wanted to focus on 4A, otherwise known as the Redwoods. So it was very exciting. As you know, we closed this unit temporarily to accommodate the seismic work that we're doing in the building. And just as an aside, the seismic work is going really well, and we're more than 2/3 of the way completed through the overall seismic work for the hospital. So this finished on time. We were able to reopen it and rebrand it as the Redwoods. The unit is really beautiful. It was refreshed, repainted, in addition to being seismically upgraded. And it's really a very welcoming space for the patients there. We have 10. We had 10 as of this morning. So it's really nice to be able to have that as an option for our patients leaving the acute unit. And then I wanted to talk about the new people the new leaders that we have at ZSFG, which is very exciting. So first of all, Dr. Critchfield is now the permanent Vice Dean of UCSF at ZSFG. He performed brilliantly in that role as an interim for a year. He's been a great partner. So having him as, the person who's going to help lead all of our team on campus and wade through the often complex issues that come before us is really, really exciting. We just named the Justin Dauterman as our Chief Experience Officer. He was previously the head of our Department of Education and Training. So now, just in time for the staff engagement survey that will be coming out, he has responsibility for that, as well as the work that we do on equity. He manages the teams who staff the lobbies at the hospital. So it's really great to have him on our team. And I will say that with Justin's hiring, the executive team at ZSFG is complete, which has not been true for the past year. So I'm delighted to welcome Justin and have a full team, which is the most outstanding team running a hospital anyone could ever hope for. And then we have 2 new chiefs of service, which of course you're fully aware of because you approved them here. Dr. Fumi Mitsuishi, who chairs is the chief of our Department of Psychiatry, and Dr. David Bain, who is the chief of urology. I'm very happy to welcome those leaders. They come with experience and a devotion to ZSFG, which I think is really important and needed at this time. And then last but not least, I wanted to celebrate our social workers. Social workers are unsung heroes at our hospital, especially in this day and age and with the patient population we serve, who are very impacted by social determinants of health. They do so many things for us, both inpatient, outpatient, emergency department, PES, in everywhere you can imagine. And we have a series of awards that some of our team received. They all deserve awards in my book. And so I'm really happy to highlight celebrating them for you. And I'm happy to address any questions or anything at all about the report that you have in front of you.
Commissioners, questions on this first part of the report? No.
I just want to say congratulations on having your excellent team in place and, celebration of the fact that they are the most excellent choices. And so we're so fortunate for that.
I can applaud many of them who are here in this room. Yes, thank you.
And just from my experience on the community side of things, I'm just so happy that Dr. Mitsuishi is now with, the heading the team at the hospital, and the decades, I guess, of experience from the community that she brings into the full space now, especially since those two spaces are pretty porous, particularly these days. So I think it's a real asset to the community.
Yes, I couldn't agree more. Thank you for recognizing that.
Having read your item number 14, I'll have to tell my wife as that the licensed social worker has been recognized at General.
Yes, of course.
she-
Many of them have been. That's great.
She, many years ago, she was the first social worker that St. Mary's had.
Wow.
And so she's never let me forget. So I call her a socialist, but in any case, no, thank you. And it said it was inaugural, so this is really the first time
Yeah.
that's been done.
It's overdue. So the awards are inaugural. And so I'm looking forward to celebrating social workers every year.
Very good. Thank you very much.
Sure.
Let's proceed to your data report.
Yes, data. So in the interest of not going through everything, I wanted to focus on a couple of charts. And a lot of what's contained in these charts is part of the questions that you asked. And so I wanted to make sure, after I go through these particular charts that we make sure that your questions were answered. So first I want to talk about, and this is also a nice segue into your next presentation, because we're going to talk about, this is about flow and access, both on our psychiatric units as well as our medical units. So the first chart I wanted to talk about was the psych chart with the percent of acute patients on psychiatry. Now, you can see very happily that this metric is in the green this month. So more is better, and you can see that this is in the green. We just, this month, got our month to date above our, where we're headed for, which is 20% of our patients being acute on the acute unit. That seems crazy that 20% would be the thing to which we aspire, but I think what that target recognizes is that this is a problem throughout the state, that people are stuck in our acute unit and can't get out. But as you can see from the trajectory of this graph, this is doing better and better. And with the work we're doing and the work we do in conjunction with BHS, we hope that that will continue to improve. That is very closely linked with the next chart, which is boarding in PES. So here, we're looking to reduce the length of stay of PES patients waiting for an inpatient psychiatry bed. And here, we're not yet at our target, but as you can see, we're getting close. So in this chart, lower is better, right? We want the length of stay to be lower. We're still in the red, but as you can see, our month to date is getting very close to the target, which is 57.8. So the fact that people are waiting shorter amount of time is a reflection of the fact that we're able to send more acute patients into the acute unit. So we've got better flow going. And mainly that's because we can get people out quicker. So that is in contrast to what we see on the med surg side. Now, I do want to point out, and this is, I highlighted this in the response to your question. Part of the issue here is that the data we're looking at are for January and February. And we would normally expect the boarding problems, the length of stay problem, the boarding to be higher and the length of stay to be longer because we're in the winter months. I can confidently say that the next time we look at this graph, then the line will come down because we're already seeing that now as we are in the end of April. The things that are helping us on the psychiatric side are things that we don't necessarily fully have in place on the medicine side, even though we have a whole variety of things that we're doing that are under our control that allow us to, move patients out of the med-surg unit more quickly. And I went into some of that in the written response that I provided. I think I'm going to stop with that because I think mostly your questions reflected kind of the big changes in these data. And I want to just take time to go through the responses to your questions about length of stay, about days in AR, and clean claims, and then the subsuspendal. So I'll stop and answer any questions you have.
You're going to then go further into the other data, or you want?
No,
Commissioners to
we're
ask
trying to be
questions?
brief here, so I'm going to hold. This
Okay.
is an experiment. Rather than going through chart by chart, I want to be able to focus on the things that stood out to you. I shared with you the things that stood out to me, as well as, we already answered some of the questions that you
Sure.
asked.
Okay, Commissioner Christian? Commissioner Green?
The questions are good.
Your questions are all answered then? Okay. Well,
I'm ready for you, Dr. Chow.
I don't really have questions because I think the charts were very helpful. And I think as you have pointed out, there has now been a reduction in the length of stay in both the PES and the acute side. And I think just being able to follow the trends because of the way now we've structured things is going to be very helpful. And I will then at that time take a look at what we're doing.
Yeah.
And with, as I said, the explanation from these data points, it will be really easy to understand what you're, accomplishing.
Yeah, I'll just highlight one thing because it shows you how creative and clever our team is the dalbavancin pilot. So in case that, because it took me a long time to be able to say that word, easily without making a mistake. But dalbavancin is a long-acting antibiotic that's given by injection. And so we have a lot of patients who come into the emergency department with skin infections. And because of their living circumstances, they need to be admitted to the hospital to do IV antibiotics. So this group of patients, instead of admitting them to the hospital, they can be given an injection and have a follow-up clinic appointment. And so that's what this pilot is. And I think it's 30, 50 patients that we've been able to identify to have them go through this without being admitted. So it's saving, if you take 30 patients, for example, and multiply that by, 5 or 7 days, you're saving a lot of hospital days. So even though we're not on target for that metric, there are many things like that. Well, not exactly like that, but there are many efforts we're taking to try to control the things that we can control, use new medications when they come available, to try to reduce length of stay and thus, reduce the number of people in the hospital who don't need to be there and can be treated elsewhere.
So have we also then done follow-up to know whether or not these people are healing at the same percent as if they came into the hospital? Because there is no question about a follow-up. They're sitting in bed.
Right. Well, that was the reason that we included in the pilot a follow-up clinic appointment to make sure that we weren't just sending them home without really understanding what they were doing. So Gabe can say more about that, but I think they're, it's going according to plan. I think we would see it in patients coming back to the emergency department and then needing to be admitted, but you can tell me if I'm wrong about that.
Good afternoon, Commissioners. Gabe Ortiz, Chief Medical Officer. The pilot has been a very big success. The patients who get treated have responded to the antibiotic. It's quite a reliable antibiotic for the bacteria that typically cause skin and soft tissue infections. And what we're learning is because these patients often have a lot going on, that extra point of contact in the ambulatory setting is actually very helpful for continuing to ensure that if they had wounds or other things, that those continue to get good care. So it's been a really great success, I would say, in that perspective as well.
Very good. Good. Commissioner?
That is very exciting. I'm not going to try to pronounce it, but I think you did flag this for us a couple of meetings ago. Maybe it was the last meeting, and I thought it was exciting then. And I'm glad to hear. I mean, thrilled to hear that how well it's going, and totally understand as much as I can about what a big deal that is. So it's really great.
And how many patients so
So I'm waiting for an update from the folks who've organized this. The last update I had, and this was quite a while ago, was 30 patients. So I'm positive it's more than that. I just don't know how much more. But they were reliably identifying 3 to 5 folks per week that qualified. It's one of our top admission diagnoses, so it fits the perfect Venn diagram as a target diagnosis because it is such a high frequency need for a patient to need to come in. And the team has been very thoughtful to not have dalbavancin be the go-to antibiotic. It's really for patients who truly need to stay in the hospital because we have lots of great oral antibiotics for patients with mild skin soft tissue infections. So they're trying to be kind of judicious and making sure that it's the folks who would have stayed otherwise for intravenous treatment that are actually getting placed into this pilot so that they don't overuse this very expensive medication.
Does the pilot have a timeline?
So it's going through the end of the academic year, and we're hoping it gets funded to then persist beyond that.
Good luck.
Thank you.
You need funding for that in terms of,
The extra clinic appointment,
Oh.
kind of to be able to staff that, to be able to provide that follow-up point of care, and some of that,
Pharmacy.
yeah, and the pharmacy costs.
but if in fact we're saving 4 or 5 days, is it not something that if you don't get the funding, that you wouldn't just be able to handle these cases in the same manner because of what you're saving?
Yeah, I believe it's included in the budget that we submitted to the mayor's office originally. The issue was we kind of, thanks to the vice dean's office, actually, we were able to scrap together money to start it before the beginning of the budget year. So that's what's happening now.
Sure.
And then if it hadn't worked, we would have the chance to either reduce the funds from the budget or redirect them, but it's going really well.
And of course, if we get funding, that's even better. So,
Yeah.
but I would hate to see a successful project then terminated just simply because we couldn't get funding and yet we're saving dollars.
Yeah.
Yeah.
No, you're right.
Okay, thank you.
Mhm.
Excellent report.
Thank you.
Oh, yes.
Yes, as I read these great answers, what's the strategy in terms of observation status? Because how long are you keeping people on OBS? And then are there any concerns about it? You know, we know that not-for-profits use it as a way of not getting dinged for 30-day readmissions. And also, sadly, many patients can't get follow-up services, especially rehab services if they weren't admitted. So what's the strategy on OBS status, and how does it impact us financially? I mean, you can count inpatient days, but what's the difference in OBS status in terms of compensation, or how you balance that?
I can start talking, and I'm going to ask Gabe to come back up, but I think, the strategy for sure is to make sure that patients who appropriately qualify for an observation stay are placed in observation status. And then once they're in observation status, that they're discharged and don't go on to an inpatient stay unless we designate them that way. So when we started designating patients as observation, because we didn't for many years, we started with the Medicare patients, and then we recently expanded to Medi-Cal. So it's really just to make sure that we've accurately identified patients and that they don't extend beyond the observation stay without appropriate documentation that they're subsequently going to be admitted. Anything else? Come on up.
Good afternoon, Commissioners. Hemla Kanzari, the Chief of Performance Excellence. So great questions. Susan is correct in her analysis. We're essentially just trying to make sure that we are designating the correct level of care for the patient's clinical status. There's many benefits to that, including revenue and flow benefits. And so while the reimbursement for observation services is lower compared to inpatient length of stay, we actually think we are having denials related to inappropriate level of care as an inpatient. So if you look at our data on the CEO report from lower level of care on the physical health side, there's actually been a dip since we went live with observation services in February. So February and March have lower level care days. That's multifactorial. It includes, I think, observation services, transitions of care to Laguna Honda, 4A opening. But I think we're trying to understand how much of the decrease is related to observation services. We believe that there is some contribution. And I'm just pulling up data now on, so observation services in January 2025, we had 78 patients that were admitted into observation services and got discharged from that level of care. So they stayed in that bucket. Their average hours in that bucket in observation services was 1.5 days. In March, we had 209 patients in observation services that stayed in that level of care and got discharged. So that's sort of like correct level of care all the way through. And their length of stay was 1.3 days. And so I think that could be contributing in a good way, both to flow, because we've trained our clinicians. They have a clock of 36 to 48 hours. And so we're tracking all the metrics in terms of finances and sort of return visits and flow. But I think right now what we're seeing, the reason we expanded to all payers was partially to influence lower level of care days, partially just to make sure that patients were in the correct level of care. And then I think there potentially are some benefits from length of stay. So that, again, aligns several of our metrics that we're trying to drive.
That's a great
It's aggregated the data by, admitted patients and observation.
Thank you for the explanation. How many of these people are those that end up being boarders in the emergency room?
Great question. So this, I will say I worked a fair amount clinically last week, and on Friday night, Saturday morning, we had 0 boarders and 0 diversion. This past weekend is some of our best flow metrics. This morning, for a Monday morning, there was 4 boarders. Historically, though, I will say that we have an area of our ED that typically has med-surg or an observation level of care patients. And so we try to prioritize patients who need longer lengths of stay for the inpatient wards to reduce turnover there. But so those observation services patients likely are in pod C of our ED because they're usually shorter lengths of stay, clinically less complicated, and go home, many of whom directly from the ED, but at the 25-hour mark, 26-hour mark.
Is there a difference in what you would be compensated if someone is simply a boarder in the ED that eventually leaves versus putting them officially on op status?
I do not think so. I'll have to confirm because they're getting sort of the same level of care. We have inpatient nurses that are providing that level of care. We provide them the same clinical service. Many systems have a physical observation unit that they use, and it is really nice to co-locate those patients. That allows for greater efficiency. We have a virtual observation services, so anyone can be on campus anywhere and have that level of care. And we could go into more detail about that, but I think there's some value to co-locating that. That was the intention with, if we have to use that area of the ED for admitted patients, we're trying to prioritize the shorter stay patients there.
And then what about the primary diagnoses, the most common diagnoses for op status?
Yeah, we can look at our own data, but it historically is things that range from like syncope, TIA, pyelo, pain, symptoms that haven't improved despite sort of initial therapy. Let's see, historically like chest pain that I think now we're discharged. Again, that's another example of similar to the DALBA pilot. We, because of the work from Dr. Lucas Sear and sort of heart failure focused work using advanced analytics, we're essentially discharging way more patients with low risk chest pain than, for example, when I trained or even 5 years ago.
Thank you. Thank you for those answers.
Yeah, sure.
Thank you. Thank you. Any other questions?
I just want to note how the data about the PES and the psych ward, the way that it's trending in the right direction is really encouraging.
Yes, it is. It's really encouraging and it's really important given the city's focus
Mhm.
on these, on patients with substance use disorders and mental health issues. And Angelica Almeida is going to come up and tell you more about that. But we want to make sure that we have capacity for patients who really need acute psychiatric emergency service and acute admissions to the hospital.
Yeah, it's so critical, and this is really encouraging.
It is. Thank you.
Thank you.
Good. Thank you very much. We'll
Yes, thank you.
go on to our next item.
Yes, item 6 is the ZSFG Behavioral Health Services Overview, and I will pull up the presentation.
Good afternoon, Commissioners. I'm Angelica Almeida. I'm the Chief Integrative Officer for ZSFG. And this is my first time presenting at JCC, but of course, I've had the pleasure of presenting to you all in my previous role with Behavioral Health Services, so it's wonderful to see you. Okay, next slide, please. So I'm going to talk a little bit today about the breadth of our behavioral health services on campus, including being a critical contact for individuals experiencing a behavioral health crisis, with a focus of not only serving people at the hospital, but having filling that gap of connections to care in the community so that we can reduce the likelihood of people coming back to the hospital. How we serve and provide treatment for individuals across the lifespan, and how we're a critical care location for individuals who are survivors of sexual assault, and providing trauma-based services. We'll also talk a little bit about our work around medications for opioid use disorder, as well as our treatment that we provide and those connections to care again. Next slide, please. So I want to start delving into more of our work to provide those critical services for individuals experiencing a behavioral health crisis. Across the emergency department and psychiatric emergency services, we provide care to approximately 6,000 behavioral health crises a year. Currently, our emergency department is the front door for individuals who are experiencing a behavioral health crisis. Just to note, this is something that changed during COVID with COVID screening. So individuals go through the emergency department for screening and then transition to psychiatric emergency services. As we've talked a lot about this, with the flow challenges that exist and the critical needs for people experiencing medical emergencies, this can not only back up the emergency department, but it can prevent individuals who are experiencing a behavioral health crisis from getting to our specialized services at the hospital. We're currently in a planning phase, doing a plan, study, do, and assess process, a PDSA process, where we're moving towards ambulances being able to directly transport individuals to psychiatric emergency services and bypassing the emergency department screening. So that'll be coming in the near future. We've also have a psychiatrist who's embedded within the emergency department to assess people who might have co-occurring medical issues as well as behavioral health needs. And have started a new pilot for individuals, for psychiatrists to assess people in the waiting room and redirect them to psychiatric emergency services as indicated. Currently, about 30% of individuals experiencing a behavioral health crisis or seen on a 5150 or involuntary psychiatric hold are discharged directly from the emergency department. Now, as we transition to people going directly to psychiatric emergency services, we expect to see this number shift. But we know right now that that's a critical need to not only assess people in the emergency department, but also to promote connections to care from the emergency department. And as you saw in the CEO report, and I know you're very familiar with, we have a dedicated behavioral emergency response team that is designed to support behavioral health needs and crisis in the emergency department. We have a team that provides support across the hospital and a dedicated team within the emergency department. Next slide. Okay. So delving into psychiatric emergency services, I'm sure you're acutely aware that psychiatric emergency services is the only behavioral health emergency room in San Francisco. We serve individuals that are both on an involuntary hold as well as voluntary patients. A couple of things to highlight: about 60% of our patients that we see are there on a voluntary status. Now, individuals may come in on an involuntary hold, but are willing to accept care through psychiatric emergency services and are converted to a voluntary status. This is in part because of some recent legislative changes that require that individuals who are accepting services cannot be on an involuntary psychiatric hold. So that may change when somebody's in psychiatric emergency services. And of course, this number varies, but roughly 16% of individuals who are seen in psychiatric emergency services are admitted to an inpatient unit. We'll talk a little bit more about this as the presentation progresses, but I think this highlights just more as whether people are seen in the emergency department or psychiatric emergency services. Most individuals are able to have their emergency resolved in one of those settings and release. So even more so critical for us to have close collaborations with behavioral health services and other partner agencies to make sure that people have those strong connections to care. Of course, psychiatric emergency services is available 24/7. We are licensed as a crisis stabilization unit and have capacity for 18 individuals, although we surge up to 21 during evening hours. And we have an integrated social work team through UCSF citywide, and a patient navigator who supports those linkage and connections to services. I want to take a moment because I know this came up in the hiring update earlier today, just to talk a little bit about the difference between our patient navigator, individuals who are non-behavioral health clinicians and their role, as well as social workers or licensed clinicians. So within the Department of Public Health, our classifications, I know it was mentioned, 2930s, which are behavioral health clinicians, which can be either licensed clinicians, either LPCCs, MFTs, or social workers, or registered. So they might be accruing their hours and working towards licensure, but aren't quite licensed yet. We also have a classification within the Department of Public Health, 2932, which is a senior behavioral health clinician. Those individuals are required to be licensed and have 2 years of experience as a licensed clinician, and so frequently provide leadership or supervision services. This is similar across different agencies, including UCSF citywide. So we have our licensed or registered clinicians who partner with us. And I also want to highlight the importance of a multidisciplinary team and having non-clinicians or health workers, patient navigators, depending on the organization they're coming from, have different titles, but how critical these individuals are. So while licensed or registered clinicians can deliver treatment interventions, diagnose individuals, non-clinicians or health workers can do motivational interviewing, support treatment planning, system navigation, et cetera. And so are really critical to relieve some of the pressures or burden on our licensed staff, also knowing that we have critical shortages of licensed staff in the field. And so this really helps to balance to make sure that people have holistic services, but that it is spread across different types of disciplines. Also important to note, as I mentioned, a patient navigator. Frequently, patient navigators or health workers are individuals with lived experience. So this provides a couple of things that are really important to our patient population. It allows for somebody to tell a patient, I've been where you're at, and their experiences, which we know can be a significant contributor to people connecting with services. It also significantly diversifies our workforce. Certainly at ZSFG, we value patient navigators, individuals with lived experience being part of our teams, and have seen some of our patient navigators or peer support specialists go back to school to become clinicians. So it's also a critical part of our workflow and also supporting individuals in the field and to diversify our workforce. Next slide, please. We've already talked about some of our flow metrics here, so this will be familiar, but just want to highlight some significant changes that have happened. We look at the length of stay in psychiatric emergency services for both patients who are admitted and those who are discharged to the community. As we've already established, most individuals are discharged to the community, and as you can see, that length of stay in psychiatric emergency services is relatively stable over time and is around 24 hours for individuals who are discharged. What can vary drastically is for individuals who are going to go to an inpatient unit, whether that be on campus or at another hospital, an LPS designated facility. In this fiscal year, that has been 63 hours on average. But as you can see, there have been significant spikes where people are waiting a long time. This creates significant flow issues into the hospital for people experiencing a behavioral health crisis. And we've made some huge gains, which of course ties directly to our length of stay on inpatient psychiatry, which we will talk about momentarily. Next slide, please. Moving on to inpatient psychiatry, ZSFG is an LPS designated facility, and we have a total of 50 beds. We have 2 units that have 22 beds each, 7B and 7C, that also serves involuntary and voluntary patients. This includes treatment provided by a multidisciplinary team, including nurses, physicians, occupational therapists, social workers, patient navigators, and other individuals with lived experience. I want to highlight the Mental Health Association, who has volunteers who come in to provide support to individuals and run groups as well. We also have 1 forensic unit that has 6 beds on campus, and that's 7L. And that allows for individuals who meet criteria for an involuntary psychiatric hold who are currently in custody at the San Francisco County Jail to be transferred to Zuckerberg San Francisco General Hospital for ongoing treatment. And then they return to jail once they have stabilized. Next slide. Thank you. So looking at a little bit of our data for inpatient psychiatry, again, this is from fiscal year 24-25. This shows the average length of stay for each month. And you can see that we've had a pretty steady decline of average length of stay, which is really a positive thing. This suggests much greater flow out of our inpatient beds. And we'll talk a little bit more about the acute and non-acute days on the next slide. While the average is 24 days, this is, of course, is highly variable. There are some individuals who are on our unit for over a year, waiting for a bed at the state hospital, for example, and some individuals who are on our unit for much less time, maybe on a 5250, which is a 14-day hold, stabilize, and are able to be released to the community. Next slide. So again, as we've already talked about a little bit today in the CEO report, we have been spending a lot of time looking at our acute days versus non-acute days. Acute days represents individuals who meet medical necessity to be on an inpatient unit. What we have seen is that individuals who are non-acute, their time on our inpatient unit has decreased. Again, this is positive. This means that people are not waiting for treatment services as long. We're able to treat individuals and successfully transition them to different levels of care. Meanwhile, we've seen individuals who are acute on our unit increasing. This is really what we want for an acute inpatient psychiatry unit. This ensures that we are serving the right population when care is needed, and that individuals who can be served in the community are in the least restrictive setting. Next slide. So while we have these dedicated service locations for individuals experiencing a behavioral health crisis, I want to take a little bit of time to talk about individuals who might be experiencing a behavioral health crisis on other units, inpatient and outpatient. Again, we have our behavioral health emergency response team that provides care across the hospital, provides consultation and responding to incidents. We have our psychiatric consult team, and this is a team of psychiatrists who also respond in the hospital to assess if somebody needs to be placed on an involuntary psychiatric hold. And of course, in an effort to increase competency for de-escalation and supporting our staff to respond to incidents, which is not only unique to individuals experiencing an acute behavioral health crisis, but we know we're working with individuals in highly emotionally charged situations. We have Crisis Prevention Institute training, which is an evidence-based intervention to support de-escalation strategies. Next slide. As you know, substance use disorders and the treatment of substance use disorders is a critical need in our current landscape. And we are very fortunate that ZSFG has some of the national leaders in this area and provides national support and consultation around our models of care. The addiction care team provides consultation and support around starting medications for opioid use disorder, alcohol use disorder, stimulant use, et cetera, and a couple of key service areas, including the emergency department, psychiatric emergency services, and inpatient medicine. What we know is about 30% of our population has a substance use disorder. The ACT team is able to consult on about 30% of those cases, but has an 80% success rate in individuals starting medications, which far exceeds the national standard. The other ways that ACT is unique is that we partner very closely with Houdini Link and Team Juno, which provide patient navigation services in the community. And the ACT team also has started a nurse liaison program, which is designed to enhance competency to treat SUD services. This started in labor and delivery because of the needs that we were seeing in that area and has expanded to other service areas, including inpatient psychiatry and psychiatric emergency services. And we're in cohort 2 right now for that. We also have the Bridge Clinic, which provides low threshold drop-in and short-term support to start individuals on medications to treat substance use disorders. They have served over 900 unique individuals this fiscal year. And again, it is on campus, is a critical location for individuals who are exiting the hospital, who might be interested in starting medications, or individuals coming to our campus for other reasons, and are able to, people are able to have appointments, but really it's a drop-in model where people can come when they're ready, if they're available, and to immediately meet with a provider or a system navigator to start to have those conversations. Also want to highlight that our Bridge Clinic provides consultation to hospitals across San Francisco around this model of starting individuals on medications. And finally, in the realm of substance use, I want to highlight our opioid treatment outpatient program, which currently has a caseload of over 900 individuals. This includes clinic-based services as well as a mobile van in the Bayview. And this provides methadone detoxification and maintenance services, as well as psychiatric support and system navigation. Next slide. As you'll see here, we provide services to individuals perinatal, throughout childhood, and into adulthood. While we've been focusing a lot of our work that's centered on adults, I want to spend time talking about how we treat infants and children in our system. This includes the Solid Start program, which provides integrated care coordination and mental health services to pregnant individuals and families. Team Lily, which has become a significant multidisciplinary model in our system that works with individuals who have serious mental illness or struggling with substance use disorders to support pregnant individuals to access care and perinatal services. Also very much a drop-in model. They have clinic every Thursday, and it's Thursday you come when you're available, so that we're reducing the barriers to people accessing care. This has really reduced the impact of pregnant individuals coming to labor and delivery who haven't had prenatal care before delivery happens. So while that used to be a normal experience, having programs like Team Lily and these innovative solutions has really reduced that. And of course, we see better outcomes for both the delivering individual as well as babies in these situations. These services are provided both in clinic and in the community, and Team Lily partners very closely with lots of city departments, including whole person integrated care, outreaching individuals, going to encampments, et cetera, to make sure people are getting the care that they need. We have the Healthy Steps program, which is an evidence-based program focused on child development, and it pairs a child development specialist with every primary pediatric contact for an individual. The goal of this is that by integrating a pediatric specialist, that we're able to have conversations with parents and with children to have early identification of behavioral health needs, not just for the child, but also for the parent, and to help make those connections, because we know how critical it is that both parents and children have access to those services. I'm a mom. I know it's very hard to meet my needs sometimes. We put our children first. And so those can often go unnoticed. And so this really allows for us to integrate that and treat the family as a unit, not just the child or the parent separately. I will also note that this has become a model across California for people to have access to this type of service. And because of the work that the Healthy Steps team has done, it is now a benefit for dyadic billing through the CalAIM program. Our infant parent program provides specialty mental health services and focuses on the relationship between caregivers and infant children. And again, really focusing on that relationship and the need to improve outcomes for both parents and children. And finally, our child and adolescent services program, which also provides specialty mental health and substance use disorder services for children through adolescence. Next slide. Okay. Talking a little bit about trauma services, ZSFG is the dedicated hospital to provide forensic evaluations for individuals who have experienced a rape or sexual assault. We also provide services for individuals who have experienced traumatic events related to physical violence or have witnessed severe violence. I want to highlight the amazing work, not only that this team does, but in advancing this work at a state and national level. There was a recent, you might have seen, there was a recent report where our team at the Trauma Recovery Center partnered with the first partner of California to release a report on best practices for serving this population. We also have emergency department case management on campus that works with individuals to provide integrated behavioral health and medical support for our high utilizers of emergency services. So individuals who are high utilizers, not just of ZSFG services, but for other emergency departments across the city. This team works very closely to support and stabilize the individual and reduce their contact with urgent and emergent care. Next slide. So in terms of successes, as you can see, we have this breadth of services, a lot happening on campus around behavioral health. And again, as we've already talked about today, we've had significant improvements with flow, which has been incredibly beneficial for creating capacity for us to serve more acute individuals and to transition people to less restrictive settings. We have increased our work around substance use disorder services and the volume of individuals we're serving, and have increased integration of behavioral health work on campus. We continue to work very closely with behavioral health services in a number of different ways. Again, in my previous role, I was with behavioral health services, so we've been able to create standard work to create better successes to connecting people to ongoing care. And we have regular meetings with key stakeholders from behavioral health services, so we can continue to monitor and improve our work and look at outcomes of these interventions. As was previously indicated in the CEO report, we've had some hiring of key leadership positions, including Dr. Mitsuishi as the Chief of Psychiatry, Joan Torres as the Director of Nursing, and Giselle Clark-Ibanez as the UCSF Manager of Inpatient Psychiatric Social Services. Want to highlight Dr. Mark Leary is, of course, still with ZSFG as the Deputy Chief of Psychiatry. And I'll just note very selfishly that this is absolutely a dream team to work with. So it makes it easy to come to work every day. Next slide, please. Okay. Looking forward, so while we've made huge strides in this work, there's, of course, still a lot of work to do. Flow will continue to be a priority for us. We know that there is more need than there is capacity in our system, and we want to make sure that we are here for our most vulnerable patients. We'll continue to enhance our partnerships with behavioral health services and other key partners. And we've really worked hard in recent months to align our work with CORE, and that includes the addiction care team work for PES and inpatient psychiatry as a key location where individuals are seen to increase our prescriptions of medications to treat opioid use disorder, enhancing system navigation for substance use disorder services. So if we are not the right location for somebody to receive care, that we help connect people to the right location. And that we are prioritizing connections to care after an involuntary psychiatric hold. And so that's actually work that I'm leading as part of this integration. So supporting connections for 5150 care as well as conservatorships. Okay, next slide. So in summary, again, ZSFG provides a wide range of services for individuals across the lifespan. And we are a key partner in mayoral initiatives and DPH priorities. It has been a pleasure to partner with this team and to learn about all these different programs and just again to highlight the breadth of work that we provide for individuals and really being a location that we're here 24 hours a day. We truly represent the safety net that exists for these vulnerable populations. With that, I will pause and see if there's any questions.
Commissioner Christie.
What a great presentation, very deep and broad, but you got through it and got us through it. So there's a lot here and a lot to think about going forward. So thank you for your work in putting this together and for the work that you and your team and your colleagues are doing throughout the system. It's really so critical and so important at this time, especially. So you as the Chief Integrative Officer, this is a new position, isn't it?
Correct.
You are the inaugural person?
Yes, the position existed previously, but it has changed significantly with me entering this role.
And this is for the general.
Correct.
And glad to hear that you're in the position, but also that that this position is key in what the city is doing, a key stakeholder and an important member of what the city is doing, just based on everything, but especially on the behavioral health piece and the needs in the community and the different parts of the community from people who are not incarcerated to people who are. And your years of experience in that space is so important and helpful to this. And so I'm very encouraged and very, very glad to know that you are there, giving your experience at this time. So is it correct to have a sense that there is a renewed effort to break down barriers and silos and to step back and take a look at actually what the landscape is instead of what it was when, like 20 years ago? Can you just talk a little bit about that broadly?
Yes, I'll say it's twofold and absolutely, I think a renewed interest and I think in ways that are really significant in that we have talked about behavioral health services as integrating both mental health and substance use for a number of years, but I think there is more interest and investment in looking at the interplay of those needs and addressing those needs holistically. So I think that's really significant. And I think renewed interest in our investments and services, how we partner together, how we really take a system approach as being the safety net for this work. We talk about this a lot at the hospital, but while somebody is at the hospital, we have to be as invested in what happens to a person in the community and vice versa, the community when the person's in the hospital, whereas these can really historically been siloed locations. So I think there is that. And I will say that, of course, there are complications because while we strive to address the current landscape we're seeing, which requires constant reevaluation because that landscape is ever changing, we are also working with some outdated tools with like the LPS Act, for example, which had some significant modifications with Senate Bill 43. It's still relatively outdated. And so there are some limitations to what we have, which hasn't changed our momentum in supporting individuals, voluntary services, utilizing the tools that we have. But I think it's really striking that balance of being innovative and also being somewhat limited in the options that we have, just given legislative limitations.
I imagine that there are conversations and efforts to really focus on the cycling that those of you who have been in different parts of the system throughout the years have seen, from the community, the jail, to the hospital, to the jail, back and forth over and over again, particularly with certain individuals who have special needs, very significant needs. And do you feel like there is progress being made on really trying to address the needs where they first appear, rather than not letting providing things that are just kind of Band-Aids that don't really help the person deal with the behavior that they are suffering on themselves, but also inflicting on other people? I'm just hoping that there is really a very significant focus on getting that right as much as possible, like figuring out what that means. The people that have the expertise, figuring out what that means, figuring it out for the person who, as an example, who gets arrested for something very violent in the community that is associated with a diagnosis, and first time or seventh time. And a sense of urgency about addressing that person's needs for themselves and for the community as a whole, because it's otherwise it's just going to continue, and more people are going to get harmed, and this person is going to become more and more, the deficits are just going to get deeper. I don't know what you can, if there's anything that you can say about that.
Well, I'll certainly say that not a surprise to anyone, we've seen an increase in acuity. And I think we've seen this over time, but a very significant shift with COVID, because people were isolated, difficulties accessing care for lots of reasons. We've seen a very steep increase in acuity. And of course, the challenges that you're discussing are not easy to solve. That being said, I absolutely think there is an interest in how we take a step back and to look at that. I also think important to note from an equity lens, you mentioned the jail, which of course is an important part for me that we integrate that, given my past work there. And just from an equity landscape, that we know that that persons of color are disproportionately likely to be arrested versus brought to the hospital. And so when we look at behavioral health crises, we certainly don't want to look at them just as people who are coming to the hospital or seen in the streets, but who's also going to custody and the work there. So there's a lot of opportunity that exists to align that. And definitely, I think there's an interest, and again, like something that is not easy to solve, that will take time. And I would just say, not just from a Department of Public Health or health network standpoint, but also thinking about our partnership with other hospitals and the larger landscape of San Francisco and how we do this work together. It's
really encouraging. And I know I don't want to say it's impossible, but it's incredibly difficult. And it might be difficult to solve even if there were unlimited amounts of money, but we don't have that. And especially, the equity lens, and just the fairness lens, if some people might prefer that word, populations that are disadvantaged anyway, people who grow up in situations where from the time that they're born experience harm that just layered on top and leads to some very serious and very negative outcomes. And then to be put in the situation where you're in the community, you have this behavior, and this happens to you. You get arrested and you get into the system, and the interventions are inadequate. So I think it is. I mean, I'm not saying this to you as someone who doesn't know this. I'm just saying that it is so critical that we get this right, and for so many reasons, from just a broad community safety reason to helping people who have been harmed and keeping people from becoming harmed in that same situation. On that point somewhat, we know that the general is the only, has the only behavioral health emergency room in San Francisco. Is there any possibility that that will change? I don't know. Maybe there had been plans where that might have happened, but with the recent difficulties in funding, those plans might be, had they existed, might be interrupted. Is there, on the horizon, are there thoughts about having another space?
I don't think there are plans to have another space current state for individuals who are on an involuntary psychiatric hold. That being said, again, we're licensed as a crisis stabilization unit, and we're not the only crisis stabilization unit in San Francisco. Door Urgent Care is one, for example, and there's a new Gary site that just opened last week, or there was a ribbon cutting last week. So while we, I think, will remain the primary location to serve individuals on an involuntary hold, there are more resources available for individuals who might be experiencing a behavioral health crisis but are able to accept voluntary services.
And I'll stop talking in a moment and let other people have a chance. But can you, regarding the child and adolescent services, is there any more context you can give us for that? It's really encouraging, first of all, that it's there, but that it's being expanded, I'm hoping in some way, maybe not necessarily at the hospital, but in the system.
In terms of just expanding services for children and adolescents?
Yes.
So I know, well, I don't want to speak out of turn. I'll just say there's, of course, a lot of work done. This work primarily sits with behavioral health services, and Dr. Farmond is the leader over the child, youth, and family system of care. So she would be best positioned to answer that. And I know that they are always looking at innovative ways to expand services. We're just very lucky that we have some of those specialized services on campus.
Well, thank you for your presentation. It includes a lot of information, a lot of encouraging information. And again, thank you for your work and wishing you the best of luck.
Thanks, Commissioner.
Commissioner Green.
Yes, well, I would echo that. It was a wonderful presentation. I have two questions. One is, we've talked a lot about people entering the system, but I'm curious to know your sense of, especially with the changes the mayor's instituted, what about the continuing care? And I also, somewhere in here, I read that the number of people that come in on 5150s that then leave is pretty high. So what are your thoughts, having really worked through this system, about the best approach to preventing recidivism and ensuring that once someone is willing to accept treatment, either for substance use or behavioral health or both, what are going to be the really key interventions that are more likely to prevent recidivism? And then also, what would be your definition of success? In other words, is it someone who ultimately becomes a peer counselor? How are we going to gauge what we would consider a successful program?
Super appreciate the question. A couple of thoughts that I have is I appreciate your question about what is considered success. And I think there's often blunt measurements that we'll use around, like, does somebody come back to psychiatric emergency services or have another behavioral health crisis or jail contact, et cetera. And while those are critically important outside of jail contact, we want people to come to psychiatric emergency services or be treated on an inpatient unit if they need that. So I think we want to assess the need, and if they're coming to the hospital because their needs are not being met elsewhere, versus the natural progression of mental illness that we know can be cyclical, and we want to be there for people who have these critical needs. So it's hard to know of what success looks like. I think that there's some measurements like that we're looking at in terms of connections to care, access to services, use of urgent emergent services or other negative outcomes like homelessness, jail contacts, et cetera. And then there are quality of life pieces. And that is a little bit more complicated to measure because we don't always have that. And so I think it's a great question. I don't have a great answer how we would do that now, but I appreciate you highlighting that need. The other piece I'll say, just in terms of this work, again, as part of CORE, we're working on really intensively looking at how we improve connections to care after a 5150 or involuntary psychiatric hold, and make sure that we're thoughtful in utilizing things like conservatorship and utilizing it when it's appropriate to do so. There's some variety in the literature around this. And so there's some statewide metrics that we look at in terms of follow-up after 7 days from a 5150 and 30 days, those being critical. But when we really look at like the best outcomes for individuals, it's them having a follow-up within 72 hours, which of course is really hard to accomplish that, and something that we're really going to be striving towards. And so what we're currently working with now with stakeholders is to think about what are our opportunities and interventions that would have the most benefit, and for immediate interventions, the least amount of effort, but the most benefit to implement immediately. And then also working across city departments to identify interventions that would have a lot of benefit, but might take more critical thinking, resources, et cetera, to think about how we implement that. So we know that we are currently sprinting and doing some intensive planning around that, but really this is a marathon, and for us to be tracking that ongoing.
Well, yeah, I'd be really interested to hear the follow-up, especially, you know, with the metrics and what you do find about how you're able to keep people within the system. The only other question, which is just minor, are you running into any issues with plans? Because we have all these lower level and decertified days. If you say someone is appropriate for an inpatient stay, are you having any issues with plans agreeing?
I don't know that we've had issues with that, but I think in part because we know what the expectation is, and I'm sure it's a pretty high threshold for billing for an acute day, so people can turn into non-acute pretty quickly. That doesn't mean that they're ready to be discharged, but I don't think that we have issues with those days being disallowed, and we've just become accustomed to it. But I think it is a relevant conversation for thinking about, like, at a statewide level, like what is considered an acute day, what meets medical necessity for being on inpatient.
Well, thank you so much, and to your teams for taking on this most challenging issue I think we're facing today. So thanks so much.
Thank you.
So I know we received a report from the medical staff in regards to the Department of Psychiatry, and as we were reviewing that, it was quite clear that it was far more than just the 50 beds, which of course as a hospital we're much more acquainted with. And you've also then described a whole broad range of services. And as we're aware, behavioral health has had a very large presence now into this space. I think when we had a large range of services, there was really a gap that was being filled. So now we have hundreds of workers out there, and a mayor's initiative that crosses all the way from housing, our social determinants and all. So it leads up to that question, which I did raise, and which, you know, the initial answer was for you to really basically try to describe to us how this integration really works, because we have a number of levels of services here at General, or staff that outreaches. So for example, are you only dealing with patients who had been registered at General, or are you working with the street teams, and how do those other teams really integrate? Are you part of, you know, the big picture at the mayor's breaking down the silos, or are we kind of working independently with a different population?
Appreciate that, and absolutely integrated in the larger work, both within the Department of Public Health and the network, as well as the mayoral initiatives. And so I think ZSFG really represents a beacon for where people access care. They don't know where else to go. This is where they go. And so this is part of our critical partnerships across city departments and different layers. And so when we're looking at connections, for example, the individuals who are identified as shared priority that street health or the street teams have identified as having critical needs, I'll often provide consultation on those types of needs, of how we can best bring somebody into care if that's necessary. But we're also working on a workflow right now. I just had a meeting earlier today about this for individuals who might come into the emergency room, and how we have pre-planned goals for what happens when somebody comes in and those connections to care. So knowing that most individuals, whether they're in the emergency department or being seen in psychiatric emergency services, are only going to have a short period of time at the hospital. Really looking at this as like a sentinel event of how do we maximize that time that they're there, and have done this pre-work. So not asking when somebody might come to the hospital, but when, how do we address those needs? And that's true, again, within the department, but also how we partner with disability and aging services for people who might be conserved, HSH for how people access those services, and how we provide wraparound care when somebody's there, just as some examples.
So are you, is it the department that's sitting there, the hospital that's sitting there working to integrate, or, I mean, how is this being done? You said that you were at a meeting, for example, and yet you have a multitude of other responsibilities at the hospital. So is there a lead that does that and then comes back and then speaks of the integration, or just kind of looking that, you know, we've all talked about this for years in terms of putting everything together, and then we build all these different, sometimes pilots and sometimes well-meaning initiatives. But so I'm looking to understand how this time this then kind of works together.
So I would say a lot of that work right now is being centered with CORE, and so that's a department-wide initiative. So the coordinated overdose response and engagement work, which not only includes response to overdose, but has integrated other significant behavioral health initiatives like the 5150 follow-up, for example. So that includes members across the Department of Public Health to work on addressing these needs. We have frequent meetings around that and reporting to Director Tsai. With that, I think with the landscape and the changes in the mayor's office in reporting structures, I think that has also given us some significant opportunities to partner with other agencies that provide services, such as HSA and HSH. And so I think our work is feeding up to these larger system-wide initiatives. So I think both a renewed interest, and I think the changes in structure have allowed for more conversation for us to be aligned in that way.
Okay, very good. Well, I wish you well. Not sure how much responsibility you're going to continue to have for this particular program versus the department, or is this part of your task now as your new office?
Part of my task in this new role. So excited to partner on this.
Good. I think it'd be good to calendar a follow-up in, you know, several months, or when it would be appropriate to understand, because all this is sort of in evolution. And I think this is such an important topic. Commissioner Kristen has pointed that out already, that it would be good to understand how we're all really coming together, and whether it's part of a larger presentation, I'd leave to the officers to decide. But I think this topic needs to be followed up. Yes, sure.
Just one more comment, building on one of the things that Commissioner Chow, Dr. Chow just noted. It would be my fervent hope, if it isn't already happening, that you, based on your experience and other members of the leadership team, Dr. Mitsuishi, I'm familiar with her experience, but I don't know the others, but I'm confident that people have different deep experience in these areas, that you are being brought to the table to talk to people about at a high level and then getting down to brass tacks about what needs to change in order for there to be a shift based on what you have experienced from your time in the system. The same with Dr. Mitsuishi, with the work that she created and brought forward at Citywide, what she knows about the community and the needs of the people that they serve. I think it's critical that the two of you and anybody else on this list who has similar expertise to bring is brought to a small table to identify the kinds of things that need to change so that that can be added to the map. That experience should not be lost, and it should not be not known by everybody else who is doing the work. I think we're going to suffer if it's not there. So thank you.
Thank you.
I think that's a good way or a segue into our next report, but I really thank you. And I think Commissioner Christian said it best, that we want to be sure that the expertise is being integrated and not ignored, and that it then leads to a successful initiative. Thank you.
Commissioners, there were some high school visitors observing the meeting today. They're saying goodbye. So say goodbye. Thank you for joining us.
Goodbye. Thank you.
We can move on to item 7, the medical staff report.
Good afternoon.
Yes, Dr. Mercer's joining us remotely.
Hello, good afternoon, commissioners and Mr. Morowitz. Can you hear me okay?
Yes.
Okay, it's wonderful to be with you today, though sorry to be virtually.
Actually, Dr. Mercer, could you speak up a little bit?
Yes, I can speak up. I am honored to present the medical staff report, and it's a relatively brief report, but one that is personally meaningful to me as a member of the Department of Emergency Medicine myself. That is our first order of business, was to review the service reports from the Department of Emergency Medicine. As all of you know, the ED is the only level 1 trauma center. So we provide emergency services for medical emergencies as well as trauma emergencies, serving over 71,000 San Franciscans visits every year and having the highest ambulance volume in the city. The report also highlighted, again, the partnership with UCSF and the School of Medicine, and highlighted that our faculty is quite diverse, spanning various ranges of experience, and with a number of clinical leaders serving in multiple roles, both for ZSFG, clinical operational leadership, as well as UCSF at ZSFG positions, as well as on the medical staff leadership. So in addition, it highlighted our residency program, and since he's in the room, I'll mention that Dr. Kanzaria is a graduate of the first class of the residency program. So a auspicious beginning. And we have host a number of fellowship programs that really span a range of services, myself including in the Emergency Medical Services, or EMS, and Disaster Fellowship. And have a very strong teaching history, I think, because of the partnerships not only with UCSF, but a number of the other hospitals and training programs throughout the city. There are a number of clinicians that have rotated through the ZSFG emergency department at some point during their intern year, who serve in various parts of San Francisco, whether St. Mary's, CPMC, and Kaiser. And I think the other big highlight from this report was the number of and the depth of performance improvement initiatives that the emergency department staff are engaged in, specifically really touching all areas of the true north for ZSFG. And many ways to look at that is that we're the department is very mission aligned with the key drivers and issues that are facing the hospital, and also at the sharp end of the stick for seeing changes and as we make improvements in these areas. So as was spoken eloquently earlier in the CEO and performance report, a number of efforts around staffing, increasing staffing and decreasing diversion and boarding in the ED have really borne really incredible fruits. I know Dr. Canzaria mentioned being able, working in the ED in the last week with zero levels of boarding. I was also able to work in an area that we really haven't been able to see emergency patients in, but had only been housing boarders for the last several years. And so that's really wonderful and transformative for our patients and our staff. Other performance improvement efforts that are impacted based on flow and issues that I mentioned prior are certainly our quality and safety. So making sure that we don't have delays in care can ensure that we have higher levels of sepsis bundle compliance. Angelica Almeida just mentioned the work in the ED and other parts of the hospital to increase access for treatments for opioid use disorder. And then finally, addressing the flow and staffing issues can also help to decrease workplace violence efforts. So there's been a lot of very active improvement in the ED aligned with the True North metrics. Some challenges that were mentioned in addition were, again, managing the vast undifferentiated patient population, the reliance on these other system-wide efforts to partner and to improve flow and operations. But I really want to thank all of our colleagues on the executive team, but particularly Billy and Otway, as well as our partners in the HR department for really helping make those, helping drive those changes that have really had a huge impact on our expanding the staff availability. All right. I can also mention that looking ahead, some of the goals that we'll continue to work on in addition to driving down diversion and reducing left without being seen are at the top of the priority, not just from a staffing perspective, but now having the full complement of types of clinicians really working on helping those teams achieve the strongest results that they can. So that concludes the emergency medicine report. And then moving on to their rules and regulations, there were a few questions. There were very minimal changes to the report. There are a few questions that I sent over some responses, but I'm happy to dive into them further. One was around consultation, the role of consultation, and appreciate the question from Commissioner Green regarding the range of emergency consultations. And I will note there have been many improvements made through the EHR to timestamp not only when a consult is made, but also what will be coming in future updates are that that bi-directional communication. That's not fully realized yet in the EHR, but it is something that is there. And I will make a note to the department to make sure to include items that are mentioned in the rules and regulations that are covered in their EHR pathways. And then there was another question about our ultrasound program. And again, I will mention ultrasound was actually one of the longest standing fellowships in the Department of Emergency Medicine. And they adhere to the ACEP guidelines around delineation of privileges for ultrasound and the amount of education and proctoring required for limited scope for emergency ultrasound and for certain conditions. I think there was a question around identifying intrauterine pregnancy, and that scope of emergency ultrasound is the one area of OB/GYN that emergency physicians have privileges for at the hospital. So I'll take any questions, any additional questions that the team may have.
Thank you. Commissioners, we received a very extensive report on our emergency department, which of course highlighted a large number of things that maybe some of us hadn't actually realized was happening, and the very impressive leadership roles that many of you, including Dr. Mercer, of course, has served. Sort of amazing. Emergency room doctors are so busy, and yet they are right there, and they've been able also to produce all those peer-reviewed reports. So I'm not sure how many hours a day that you actually all have. I think the emergency doctors must have more than 24 hours in order to do all of this. But let me ask my fellow commissioners for questions. No, you're satisfied with your answers, and you are too. Okay, so Dr. Mercer, you've done it for your department. Your department has done well. We're very pleased with it. And we'll move on to your business related to that department and the remainder of your report.
Thank you. The only other business was reviewing the rules and regulations changes for emergency medicine, of which there were just some minor typographical changes and no substantive changes.
Okay, so so we have the emergency medical rules and regulations. Is there a motion to recommend them to the commission?
So moved.
Second.
So now we have any other visitors in the room, or?
No other visitors.
Oh, okay. Then we can take a vote. All those in favor, please say aye.
Aye.
All right, thank you so much,
Thank you.
Dr. Mercer. And we can move on to the next item, other business. And I believe Dr. Critchfield might have a comment to make.
Thanks, Mark. Can you see and hear me okay?
Yes, sir.
Oh, great. Thank you. I'm so sorry to have joined you late. I was meeting with some lawyers about another matter, but really glad to be. And I was getting some announcements, some congratulations from Tangerine and Mark about my new role as the vice dean. So thank you. And I just wanted to say, particularly with Dr. Chow, you and I and Mark met in 2007 when I was the chief of staff. And so it's just been a remarkable relationship we've all shared through this venue. And I'm really thrilled both to be in this role and just have great respect for the unwavering support this body has given, and particularly you and Mark, just long-standing. So thrilled to be in the role. And I want to thank you all for the partnership we have with UCSF and DPH, and really excited to be in the role. But Dr. Chow, Dr. Mark, a real call out to you. You guys have been real highlights. Thank you.
Thank you, Dr. Critchfield. Any other comments or questions, commissioners, on this item?
Well, I just want to congratulate Dr. Critchfield. Yes, I remember as you were chief of staff, and meanwhile, you've risen to the highest ranks from UCSF at general, and congratulations. Couldn't think of a better person to be appointed by the dean.
Thank you. Appreciate it. Thanks you all for have taken a moment. Thanks, Mark.
Sure, of course. We can move on to the next item, which is public comment. And we do not have anyone in the room who's not staff. So we can move on to a consideration for closed session.
A motion is in order.
Move to go into closed session.
Second.
All those in favor, please say aye.
Aye.
All right, please give me 30 seconds to take us there. If anyone's watching from the public, we will not be seen or heard while we're in closed session, but we will be back. We are back in open session. Commissioners, you approved the credentials report and PIPS minutes report. Please consider a motion to disclose or not disclose other discussions held in closed session.
I move that we not disclose discussion held in closed session.
Second.
All those in favor of not disclosing discussion, please say aye.
Aye.
Great. And finally, please consider a motion for adjournment.
So moved.
Second.
All in favor, please say aye.
Aye.
All right. Thank you all the presenters and everyone who participated today, and have a lovely day.